I am now excited to turn to this panel, which I've been looking forward to all day. So I just want to dive right in, okay? So Chris and Dan, I'm hoping to start with you both because I admire you both so much. So I'm excited to be on the stage. Research around, I guess the research approaches around nutrition and public health have really changed significantly over the last 3 decades. I mean, really in big ways. But it's only recently that the tools for research have caught up. So I'm wondering how that affects our ability to really bridge the gap between food and health and where we are today because of all this. So maybe, Chris, I turn to you first.
Sure. Thank you for that question. When I think about the past 3 decades and the beginning of my training, I was reading a lot of literature on one-on-one behavior change, which is really important. But as the decades went on, our sort of the paradigm shift in research started to think about multi-level, multi-systems approaches, whole of community approaches, structural and social determinants of health. And as we began to think more broadly about what ultimately impacts our health, we needed to develop tools to measure those things. So when you think about the food environment or the food system or the built environment or measures of racism and discrimination, you need valid and reliable tools to measure those things in your research studies so that you can conduct, as has been spoken about, trials that produce the evidence. So, creating tools that are valid and reliable is a whole science in itself. And some people spend their time on methodology. We now have system science. We have big data. We have geocoding and GIS. We have lots of things now that we can use to really understand the big picture and the environment that we're trying to study. It doesn't mean we shouldn't still execute one-on-one behavior change. That's essential, particularly in healthcare. But the work I do in communities with disadvantage across America, it has a lot more to do with the environment and the zip code where people live and the structural and social determinants that are impacting their health. And so interventions like produce prescription and food as medicine that's working to sometimes grow the produce, distribute it equitably, and impact someone's diet at even more of a population level is really different. So the research has evolved a lot, the methodology has evolved, and I think many of us are working really hard to make sure that the research is producing the rigorous evidence we need to impact policy.
Thank you so much, Dan. You've worked a lot on this idea that we need more research to do what Chris is talking about.
First of all, thank you for having me here. I saw that 8 members of Congress are going to speak at this program. I said we'd be here till 8 o'clock tonight. So speaking with experience, I'll try to not continue that trend. Second of all, I have to say just a minute about Zoe. When I watched her, I thought to myself, every family when you can be up and you can be down.
Yep.
And it doesn't kind of matter what you've done in your life. And it just struck me. I've faced that in my own family as well.
Sure.
How we have to realize that these problems are universal.
Absolutely.
So let me just say, one, it's great to be here at Tufts. I want to make one comment. That is, our federal feeding programs, the United States, are the best in the world. Nobody even comes close to America when it comes to SNAP, school meals. School meals is arguably the most successful of all federal social programs, and WIC. And there are many, many others as well. But we shouldn't be afraid to do research on these programs to see how well they are working and whether people are eating better and living longer because of the programs. I think the data will probably show it does work well, but we shouldn't be afraid to look at the data. And the data may show, for example, the consumption of sugar is something that we should be working against. Consumption of sodium. How do our programs do on those particular things? That is the 40 to 50 million Americans plus the 20 million kids that are on our school feeding programs. What can they be doing to eat better, to reduce their sodium, to reduce their sugar, and to be healthier? And I commend the administration, particularly on the school meals program, for the work that they have been doing. These programs were established, interestingly, they have a national security focus to them. Why do we have the National School Lunch Program? It was established in the late 40s because half the people drafted weren't eligible for military service. So the head of the Selective Service came to President Truman and said, we got a problem here. And out of that came the National School Lunch program. And basically all of our federal feeding programs are basically focused on having a healthier population so we can be a stronger country as well. The other point I would just make in terms of research is so important because it builds a bipartisan base. And Dari mentioned this at the beginning of his thing. If these programs, if our federal efforts aren't bipartisan, they are doomed to constant conflict and potentially failure. So I want to make one point that the previous one of the previous speakers wrote is that the problems affecting medicine, health, longevity, and disease affect all Americans, not just people at the bottom of the economic scale, although they are hit harder than everybody else, but they affect maybe not the very, very rich. All right, although I've seen some very, very rich people with type 2 diabetes as well. But these are programs that affect the health of America in general. So we need to look at this whole thing from this holistic standpoint of figuring out how we can have a healthier America by not being afraid to look at the data so we can keep our federal feeding programs as strong as possible, but also keep the programs bipartisan so Congress continues to provide the resources that we need in the future.
Thank you, Dan. I'm wondering if you can answer sort of quickly. You mentioned that research makes things more bipartisan, but when science is under attack, and especially by members of Congress, how do we get around that? Just quickly.
Yeah, this is a general problem. This doesn't relate to food, and it's part of the nihilistic view of life that we have seen in our recent politics, and it's not only just in politics, but it's in the faith-based community in many cases and elsewhere. And all it means is the old typing test. Now is the time for all good men to come to the aid of the country, for all good men and women to do the right thing.
Non-binary
thing. And, all we can do is continue to try to preach the truth about science. And sometimes science makes it hard politically as well. One example is, the SNAP program doing its best to promote health? Or is it just doing more to promote quantity of food and not is diet quality a bigger part of it? Data will kind of demonstrate that, and so that's why research is so important.
So important. Thank you so much. Dr. Ojikutu, I want to turn to you. Chris talked about the idea of location really, really mattering, and your research centers around a lot around that. So I'm wondering what type of research can support efforts to reach communities that lack access to healthy, affordable, delicious food, when we're talking about communities that have been, just violated. They have been affected so much by marginalization and inherently racist and misogynist practices for decades.
Thank you so much for having me, and I really do appreciate that question. Before I jump into research, I think it's important to say that, so the Boston Public Health Commission is our city's health department, and it's one of the oldest, if not the oldest, health departments in the country. And fundamental to our work is health equity, and it is about dealing with structural racism. That's all we do for the most part, and we're actually thinking about changing our mission statement to say that is what we do. And we've been doing this for decades. It preceded me, and I think it's really important to say that, to put into context that we have done a lot of programming. And Mayor Wu, if you heard her talk, a lot of the things that she's talking about, having a mayor's office of food justice, having all the farmers markets, having the co-ops that was written in the Boston Globe this morning, all the work that's being done with Age Strong, working with the elderly, working very closely with Boston Public Schools, all this is really progressive work that's happening here in Boston. The problem is that we haven't made the progress that we should have made. And I think that's the issue. And that should tell us, no matter what research we put into this, we need to do something differently, And I really want to emphasize that when you look at the data that we've collected and you think about life expectancy around Boston by place, because you were asking me about place, the same neighborhoods, the same census tracts where life expectancy is low is where food insecurity is highest around the city. Okay, the same places where, you know, life expectancy is low, where we have high premature mortality, where we have high rates of diabetes, high rates of other chronic diseases. These are the same places where food insecurity is highest. So they're not disconnected, and sometimes we get closed in and boxed in by our work. And I have to be honest, I'm a health equity researcher, so I do a lot of work. And my health equity research prior to coming to this particular job was really focused in on structural determinants of health. So a lot of the things you mentioned about structural racism and its impact on HIV specifically. So myopically focusing in on HIV. And I thought to myself, a lot of what was happening in terms of people using the prevention, care, and treatment resources, a lot of the issues that we talk about with food insecurity, a lot of the issues that are sort of creating the problems that I just described about life expectancy and chronic diseases, this is about income inequality. This is about not having a universal basic income. This is about people, groups of people in neighborhoods who have no sense of economic mobility. If you don't feel as though you can attain, you can achieve, you can move forward, why are you caring about the quality of food you ingest? I mean, that's just basic. You know, and I'm just going to speak as a doctor. I know from talking to many of my patients, I know that they were food insecure. Yet, they didn't talk about it that much. What they were talking about is, you know, I don't have a job.
Right,
you know,
right.
I had a hard time getting here. You know, I'm going to go and eat the crackers that you guys have in the cabinet or whatever that'll fill me up. That's not the priority. So no matter what you're educating people on in terms of nutrition, no matter how much time you spend in programming, unless we have a structural change, unless we think about these issues of economics seriously and we commit to doing something differently, we're not going to get anywhere.
Thank you so much for outlining all of that. And I think, Diana, that brings me to my next question, which is we need a movement. We need a movement for things like a living wage and things that we don't normally talk about at public health conferences. So I'm wondering if you can talk to me around how this food is medicine movement has changed. You said particularly over the last 15 years, and I'd love to hear a little bit about that history.
So, hi everyone, I'm really happy to be here on behalf of the Rockefeller Foundation. And I just want to go back to something that's coming up right now, which is data is very important, and the Rockefeller Foundation is investing in this space. We made a commitment last fall to mobilize $250 million to support the National Research Initiative for Food as Medicine in partnership with the American Heart Association. So we deeply believe in the need for data. But also, we need the storytelling, and that's what's really going to drive this data home. And I commend the two women who came here earlier. I think it was Zoe and Concetta, who came and bravely shared their story and their lived experience. And that's not lost on us, you know, as researchers, that the data will get us very far. And there's a lot of things we still need to know about food as medicine, even though it's very obvious food is good for health. You know, we get questions from health plans about duration of interventions and the appropriate dosage and the cost and how it's going to bring down the cost of healthcare. But together with the data and the storytelling, that's where the movement building really comes in. And that's what the foundation is really looking at, is how to transform healthcare delivery so that it's serving people through food.
I love this idea of data and storytelling. And Chris, I'm hoping you can elaborate on what Diana said. And Diana, please feel free to jump in as Chris is talking. But data collection is really, really expensive to do well. And so you're seeing shifts around how it's becoming more multidisciplinary so that it can be done more efficiently, probably less expensively, and better, right?
Yeah, we're seeing more and more calls for interdisciplinary research projects, and some are even multi-university. The largest grants out there, 8 to 10 million, often have 4 universities involved, and there's qualitative work and quantitative work. And just to build on, you know, what both of you said, some of the research, I'm fortunate enough to be a co-PI on an NIH grant in the Mississippi Delta, where we're beginning with economic development. So growing the fruits and vegetables, living wage payment to the Black farmers there who want to get back into farming, but only want to do it if it provides a living wage and economic vitality and mobility, and it feeds the people right in the region, which then converts to a randomized controlled trial with the Delta Health Centers looking at blood pressure and hemoglobin A1C, et cetera. So these are large, $6-7 million trials that some of us are fortunate enough to have, but it's because we're investing locally as well.
Sure.
Data is really important, but when the study is over, most of us want to know we made a difference where we were working. And in this case, it really does invest in people.
Yeah.
And as you said, I can't overstate the economic part of this.
Sure.
And so the more we can do projects like this, there's another one going on in California, and I'm sure there are many others as well. We want to be more aware of them, we want to be supportive, and we want to tell the story so that we can really get that multi-level investment, right, from seed all the way to society. And the only way we're going to do that, unfortunately, is with research funding.
Yeah.
It's really expensive to do this work, but if it's high quality and the measurements are rigorous, we're going to have excellent data to push policy forward in the next 1, 3, 5 years. So many of us are working in that way to really invest in the communities as well.
Absolutely. Thank you. Dan, you wanted to comment?
Yeah, this is such a complicated problem. Food is medicine, and it involves people's backgrounds, income levels, status, access. It also involves what you should eat to keep you living a long time. And all of that requires research. I just read 2 books, one by a guy named Peter Attia, Dr. Attia. You may have read about him, featured in the New York Times. He's got all these exotic new ways that you're going to live to be 125. And by the way, I'm buying all the books he writes. and then Dr. Mark Hyman, who writes about the same thing. The truth is we're entering this new era of artificial intelligence, and we'll be able to determine with much greater specificity on a precision nutrition basis what you should eat and what you should eat. It may not be the same thing. All right. So, and the second factor of all of this is that this issue of healthcare costs is going to bankrupt us as a country. It's costing hundreds of billions of dollars for Medicare and private insurance carrier to deal with preventable diseases that affect the poor, the middle income, and the upper middle income. So as a practical matter, we're going to have to deal with this issue. It's not going to go away. So we're going to have to look at this issue holistically across the board, which is difficult because everybody comes at this issue from their own perspective. And H.L. Mencken once said, for every complicated problem, there is a simple and a wrong solution. Well, I'm not sure that's true here, because I think that's what research does, is try to give us better solutions to the problem. But we're entering, the bright side of this, we're entering a new era where the sky's the limit in terms of our scientific capability. What I'm not so sure about is what our political and social capability is going to be able to help us deal with the problems of average people
Sure.
and lower income people.
Sure. Thank you, Dan. Diana, I wanted to go back to you, and the idea of data plus storytelling is so powerful and so effective. And one of the things that I admire about Rockefeller is that you're collaborating with folks you might not have collaborated with a decade ago, like the American Heart Association and others. These sorts of unusual collaborations are key. Can you talk a little bit more about that?
Yeah, so with the American Heart Association, we are co-designing this Food is Medicine initiative to look at those hard questions. We're calling it the No Excuses Research Initiative. We're going to try to prove once and for all with definitive evidence that food is medicine is good for health, reduces healthcare costs, and reduces utilization of the health emergency room and other expensive healthcare services. So that's a wonderful partnership that we're kicking off. And we're excited that we were going to make all these research findings publicly available because that's really important too. There's a lot of the sector that has data right now that is not shareable. And so one of our commitments through this research initiative is that it will be available, the findings will be available publicly. But another initiative I wanted to mention is, that was mentioned earlier by Representative McGovern, is our partnership with the Veterans Health Administration. That program is really significant, one, because we have a number of folks at the table that helped us to design it. Veterans, unfortunately, in this country face disproportionate rates of food insecurity and diet-related disease in comparison with the US general population. And we brought together veterans, clinicians from the VA, the Office of Food Security, which the VA now has and has established. Incredible. Ourselves at the Rockefeller Foundation, some researchers to support us, thank you, Dari, and other implementers, including About Fresh here from Boston, to help us design a prescription program that will reach 500 veterans in Salt Lake City and Houston. And we are centered on those research questions. Yes, it's going to deliver an incredible and important service for veterans, but we're also going to walk away with important evidence that this works. That's the hope.
I love it. That's so great. I want to shift gears a little bit, Basola, because you were on the front lines over the last 3+ years now. And I'm wondering if you can talk about how the city of Boston is thinking differently now about how to engage with communities because of the COVID-19 pandemic. It must be very different than it was in 2019.
No, it certainly is, and it certainly is, but it also certainly isn't. I should say that.
Sure.
Because it's not that we didn't know how to engage communities. I don't know that there was as much of an investment to do so.
Yeah.
You know, there's really, you know, the COVID-19 pandemic really amplified the needs, you know, so I think that's important. Just to speak about food insecurity during COVID, just within Boston, you probably already had data from Massachusetts. The Boston Public Health Commission did conduct a survey in 2021 looking at food insecurity across the city and found that amongst Black individuals, amongst Latinx individuals, approximately 40% said that they were food insecure, whereas amongst white individuals, it was 7.9%. I was actually a little bit surprised that there was such a differential, because a lot of people were suffering during COVID-19, just to be very clear about my impressions of that data. And interestingly, in terms of neighborhoods, Mattapan, Dorchester, and East Boston had the highest levels of food insecurity. So what was done during that period of time, during COVID, which we would like to continue if there's funding to do it, is that there was mobilization and empowerment amongst community coalitions, which was really key. And what they were doing was certainly trying to increase health education, health literacy. They were trying to engage people in research, so the initial COVID-19 vaccine trials. And they were boots on the ground when nobody else was boots on the ground at the time. Everybody else was afraid. So you had people like the Black Boston COVID Coalition, you had La Colaborativa, you had Equity Now and Beyond, immigrant organizations that were doing this work. But they were also connecting people to resources. Right. So they were bringing food baskets into people's homes. They were really doing the things that needed to be done to meet the incredible gaps. The problem, as we all know, is that when an emergency ends, the impetus to do this kind of work ends. And there's sort of a flat line that we get into between these emergencies. And right now, these organizations, they don't really have the funding to do that kind of work. And that work is so critical because they could be continuing. It's not like food insecurity went away. Maybe it decreased a little bit since the height of COVID, but it hasn't gone away. So then how do we, as a city, as a state, as a country, figure out how to maintain that type of empowerment and mobilization amongst communities? So one of the things we're doing within the Boston Public Health Commission is we're starting a community health equity empowerment fund. So we have some money from the American Rescue Plan Act that we're going to be offering to communities to partner with community health centers to do this kind of work and to address issues like food insecurity. But it's not enough. Right. There has to be a concerted effort. And if I, could design a research study looking at that, I would really want to see how well that truly works long term. How is that sustainable? Is it the way to go in terms of addressing these overwhelming issues in terms of health inequities beyond dealing with COVID-19 and, say, vaccine uptake and access? So to me, that's one of the things that I would do in terms of research.
But that boots on the ground, that's going to be effective no matter what. Those community coalitions are going to be effective no matter what. Dan, how do we get the politicians to get behind this kind of thing?
Well, first of all, we've had a coalition of urban and rural, liberal and conservative interests in this country that have fought for 75 years on food insecurity. I see my friend Rick Leach out there, who's been a leader in both domestic and global efforts on food. This is one of the few areas where historically there has been bipartisanship, and there has not been this excessive vitriol and polarization. But it's fraying now. So the most important thing we can do, Massachusetts is different because I think your politics allows you to pursue perhaps a more progressive agenda than maybe the country as a whole. We must preserve this bipartisan coalition for food and nutrition security. I don't think you can talk about food security without talking about nutrition security as well. It's just not volume of food, it's the kind of food intake.
Can I add one thing here? Because this is so important that is somewhat different in Massachusetts, but there was a report that came out by Blue Cross Blue Shield Foundation in collaboration with the Health Equity Compact, which is a group of 70 leaders of color. Many of them are leaders of color. I'm a member of the group, and it reveals some important facts, right? So we should all have a moral imperative to do the kind of work that we want to do, to address food insecurity, to address health inequity. But we need something more than the moral imperative. We need the economic case for actually dealing with this. So according to the data that they collected, it costs Massachusetts alone per year $5.9 billion to address years of life loss, premature mortality, labor force loss in terms of Black, Latinx, and Asian individuals within the state of Massachusetts. So inequities actually cost us, as taxpayers, $5.9 billion. This report is online. It's astronomical. Yeah. And if you think about that just across the country, this is one of the reasons why we need to be thinking about strategies like working more collaboratively, like working boots on the ground, like working in a bipartisan way, because this is not just about one group, it's not about one political party, this is about all of us.
I love it. Perfect way to end this panel. Thank you so much. Huge round of applause for you all. Thank you. We're going to go now to part 2, but I want to thank you all for being here so much. Thank you.